Hello, my name is Teresa Mulaikal. I'm here from Columbia University in New York, where I practice as a cardiac anesthesiologist and an intensivist. I also have the privilege of serving as the core residency program director. I am here to speak to you about resident remediation, strategies for support and success in our workplace. Our objectives today. I'd like to define remediation in medical education, discuss its incidence and prevalence, not just in our field, but also in other specialties, to categorize types of remediation, to discuss strategies for support, and finally, to think about pathways for alternative professional pursuits when our residents may not be suitable for our field. How do we define remediation in medical education? This definition by Collette and Chow is one that I really like. The act of facilitating a correction for trainees who started out on the journey towards becoming a physician but have moved off course. I find it very gentle, and it indicates that we are all on this journey together and here to help our learners when they deviate from the path. Why does it matter? Trainees on remediation are at risk for attrition. They can leave our residency programs, they can leave our field. And failure to complete residency is extremely expensive. This is data from the US, but the annual cost to train residents in the United States is estimated to be about $140,000 to $180,000. And many of our students who come to residency come with a significant amount of debt, and greater than $200,000 for more than 40% of residents starting residency. Wherever you practice, it is a significant personal and public investment. This is also a serious time investment for faculty. And trainees on remediation may not achieve board certification. These are program metrics that are reported internally to our institution, such as the Graduate Medical Education Office, but metrics that are also reported nationally to the boards that accredit us, such as the American Board of Anesthesiology or the Accreditation Council for Graduate Medical Education. And finally, there are serious patient safety considerations. This is a study published in JAMA Surgery in 2024 that looked at patient outcomes following endovascular aortic aneurysm repair for vascular surgery trainees. The EVAR is a very common vascular surgery procedure. And this study looked at over 4,000 patients, over 200 hospitals, and about 327 surgeons, and found that there is an association between individual milestone ratings and major complications in early surgical practice. And they looked at these milestones 6 months prior to graduation. They defined major surgical complications as major adverse cardiac events, death, stroke, intraoperative kidney injury, conversion to open, intestinal ischemia, and respiratory failure. This study indicates that milestone data can identify trainees at risk for poor patient outcomes, and really this was the purpose of the milestone creation, and that remediating in a supervised environment such as residency and fellowship really does protect our patients. The ACGME National Milestone Data was developed in 2013, and this was a way of tracking skills and competence development for physicians in training. And our field has 23 milestones, and each of them are subcategories of the core competencies, and those were developed in 1999. And as you can see here on the x-axis, there's the resident year level, and on the y-axis, the milestone rating. There's a mean and there's an interquartile range, and this data is published annually by the ACGME. Here you see an example of 2 milestones, situational awareness and crisis management, as well as postoperative care. This data is reassessed and published annually, and as you can see, there are significant outliers. If you have a resident who's an outlier, particularly at the bottom end of the spectrum, this needs to be flagged by the Clinical Competency Committee as a difficult resident or struggling learner and one that needs additional support or remediation. The incidence of remediation is not the same as the incidence of attrition. The incidence of remediation is going to be highly variable depending on the training program because it does depend on how the training program defines remediation or how the department does. It could be by test scores, it could be by clinical performance or professionalism or a combination of these items or categories. But we do know that residents on remediation are at risk for attrition. And the highest rate of attrition is in surgical subspecialties such as orthopedics and neurosurgery. What do we know about the incidence of remediation in training programs? This was a single center study of categorical general surgery residents that looked at over 30 years of experience. And they found that the incidence of remediation in their program was 22%, 17 residents. The majority of these residents were identified PGY 1 year. And the majority of residents had overlapping areas of remediation, such as clinical, professional, and academic. Of the 17 residents on remediation who graduated, most had unresolved issues at graduation. And following them after graduation, 2 were not able to obtain medical licensure, and 7 were not board certified. This is a study from the field of obstetrics and gynecology from Harvard Beth Israel. It was a survey of OB-GYN program directors, and it found that the majority of programs had residents on remediation, about 3 plus or minus 1 during a 4-year training period. And the main areas of remediation were professionalism and medical knowledge. And you can see from the bar graph here that the faculty feedback was essential to identifying residents and developing plans of support. So please know how important you are as faculty in this process. What about our field, anesthesiology? So this is a 10-year multi-center study of 4 high-caliber programs in the U.S. that looked at over 800 residents and found the prevalence of residents in trouble to be about 25%, which mirrored the data at the national level for other training programs, including psychiatry, family medicine, internal medicine, and general surgery, which was about 6 to 26%. And this study found that the overall graduation and board pass rates were consistently high for residents with no or isolated deficiencies, but that those residents who were deficient in American Board of Anesthesiology essential attributes or core competencies were at high risk for not graduating and for not achieving board certification status. What are the ABA essential attributes? These are 7 core elements to our field, and as you can see, things like high standards of ethical and moral behavior, honesty, integrity, and responsibility, someone who learns from experience and knows their limits, someone who's able to react to stress in an appropriate manner, someone who has no documented history of substance use disorder, someone without cognitive or physical impairment that may preclude acquiring and processing information in a timely manner without accommodations or with reasonable accommodations, and someone who demonstrates respect and dignity for our patients and is sensitive to the diversity of our patient population. Our board requires that every 6 months our faculty on the Clinical Competency Committee gather and report whether our residents have any deficiencies in the ABA essential attributes. And a deficiency in a single attribute will render the 6-month training period unsatisfactory. We are also required to report whether our residents failed Part 1 of their ABA exams, which is the written component of the board. 2 consecutive unsatisfactory training reports is an automatic 6-month extension of training. What are the categories of remediation? These are categories that you'll see reflected in the literature and also that we use in my training program at Columbia. There's academic remediation. These are residents who have difficulty with test taking. It could be an in-training examination. It could be a written board certification. It could be an oral examination or an OSCE required for board certification. Then there are residents with challenges related to direct patient care. In our field, it could be procedural or technical difficulties, situational awareness, or crisis resource management in the operating room or the intensive care unit. interpretation of monitors, and understanding their impact on patient care. And finally, there are residents who struggle with professionalism. It could be accountability, reporting to clinical tasks on time, honesty, disclosing medical errors, or being honest in your interactions with peers and colleagues. And finally, this could include challenges like substance use disorder. When we think about strategies for support or resources we can provide our struggling learners, I like to divide this up into two categories: interdepartmental or extradepartmental. Interdepartmental resources are very useful because these are specialty specific and it's very targeted. For example, you and I and the other faculty who are anesthesiologists know exactly what it takes to be a good provider, and we can coach our residents accordingly. Extra-departmental resources. This is when you seek the advice or the help of your designated institutional official or your graduate medical education office. Remember, these resources are institutional, and so they will be resources that have helped trainees across all programs, not just ours, and they can be extremely useful. You may need to consult with human resources and legal as well, as residents who have difficulty may progress and improve, or they may have alternative paths that result in probation. I believe that a holistic approach to a struggling learner is likely to be most effective. Remember, being on remediation for a learner can be extremely stressful. We have a very close affiliation with our Department of Psychiatry, and every resident in our program has access to a psychiatrist and 8 confidential sessions completely free of charge where they can speak to a health provider about anything that they're feeling. And from what I've gathered and the feedback that I've received from my residents, speaking about test-taking strategies, about stress and managing work and managing home is extremely useful. And then some residents have undiagnosed medical conditions such as anxiety and depression. And speaking to a professional and even seeking medical support and medication management can be extremely useful. And again, this is not in our realm of expertise, and it's certainly fair as a program director to get the help of an advice of a colleague. I'm going to review each category of remediation: academic, clinical, and professionalism, and discuss strategies of support that we've found to be successful in our training program and also have been documented in the literature. In the U.S., the American Board of Anesthesiology offers an in-training exam once a year. Residents who score greater than 30% on their in-training exam have a greater than 95% chance of passing Part 1 of their written board exams. We mandate that all our residents take the in-training exam, and for those who do not meet this 30% benchmark, we assign them a faculty remediation coach and place them on academic remediation. Their coach, as well as I, will sit together, will assist with creating a focused study plan, which often involves advice about time management. And the academic coach will also review missed keywords, either of the in-training exam or of the board exam if they have not successfully passed it. We will meet regularly, at least once every 2 weeks, to review progress and to check in with the resident. I always offer mental health support. It's difficult to mandate this, but in my experience, it's been extremely helpful. And again, in our institution, it's complimentary and completely confidential, so there really is no downside. Some trainees may require a leave of absence. I will assess the needs of the resident and also discuss this quite candidly and openly with them. Our residents have come from a lot of different backgrounds, and there are sometimes really difficult things that happen outside of work that may make it extremely difficult to perform well on a test. Perhaps you've recently lost a family member. Perhaps you're coming back from some sort of parental leave and you've just had a child and your child is not well. These are things that really take priority over test taking, and I have found for my residents who've taken advantage of a leave when it's appropriate that they have returned and done much better after the time away. There are residents who may not require a leave of absence, but who may benefit from a rearrangement of the clinical or block schedule or the call schedule. For some of my residents who are retaking a very high stakes exam, such as their boards, I will readjust the call schedule in the couple weeks before they take this high stakes exam to make sure they don't have as many 24-hour shifts and that they're a little more rested and prepared going into the exam. You may consider rearranging the block schedule. For example, if your resident is scheduled to do a really difficult, demanding ICU rotation from a work hours perspective, perhaps you switch that block with another resident who's not retaking their written exam and optimize his or her chances of doing well and studying. And then their testing accommodations. Most boards in the country and internationally will offer testing accommodations for students who have formal assessments or a need. In the U.S., the American Board of Anesthesiology certainly will consider testing accommodations. This process does not involve the program director or does not involve the hospital. The resident will write to the board specifically petitioning for testing accommodations. They're required to submit proof or a formal assessment. And I certainly will share this process with them and allow the resident and their own provider to decide whether or not it's appropriate to apply. I want to share this recent publication from Anesthesia and Analgesia that was just published in 2025. And this is by our board, the American Board of Anesthesiology. About a decade ago, in 2014, the ABA decided to administer staged written exams, and all residents in the country were mandated to take an ABA basic exam at the end of CA1 year. And this change was designed to encourage residents to develop a strong foundation in medical knowledge, as well as for programs to identify residents early who may have certain knowledge gaps. And the exam covers pharmacology, physiology, anatomy, anesthesia equipment, and monitoring. In this 10-year retrospective study, our board found that women, Black residents, Hispanic residents, older residents, residents of Middle Eastern or North African descent had lower first attempt pass rates, but that overall, over 99% of residents passed the basic by third attempt. Now, this demographic of residents has been identified, this demographic of learners, I should say, has been identified in other areas of medical literature when you look at MCAT performance and USMLE performance. So it is likely that these learning gaps existed prior to residency, but it is very important to encourage this demographic to develop plans of remediation and support, and it is reassuring that eventually residency programs do a great job of achieving this 99% pass rate. There are learners who may benefit from clinical remediation. These are residents or students that have difficulty with direct patient care. Perhaps their technical skills are far below peer level. They may benefit from extra time in the simulation lab. Here you see some of my PGY1s being instructed by one of my chief residents in things like intravenous line placement. You can also tailor elective rotations to address procedural deficiencies. For example, in our field, perhaps a resident who's struggling with central line placement may benefit from more time on cardiac anesthesiology or on a liver transplant anesthesiology rotation. And I've also taken some advice from the EM literature, a field that has a lot of similarities with ours. For their residents who have difficulty with airway management skills, they may spend more time in the OR with anesthesiology or give lectures on their areas of deficiency so they can also read and prepare prior to performing. There are residents that may struggle with situational awareness. These are learners that have difficulty interpreting cues from the surgical field, may not recognize when a patient is deteriorating, cannot generate a differential diagnosis. What can we do for them? I'm citing some emergency medicine literature. Again, this is a field with a lot of similarities to us. These residents can participate in the hospital's rapid response or code teams at Columbia. This is something we regularly do for our residents. It's required. Additional simulation sessions targeted at patients with critical illness is also very useful, where a faculty member will design a simulation and then give the resident feedback at the end and debrief with them. It is is useful for residents to actually prepare lectures on topics such as the ABCs of trauma, perioperative ACLS, surviving sepsis. This allows them to read before a high-stakes situation and hopefully apply their knowledge to direct patient care. It is very useful to pair residents with a smaller group of core faculty that can assess their progress over time, give them direct feedback on a daily basis, and work to build a relationship. Residents can also be paired with senior residents or chief residents or fellows. I find that sometimes this is a little bit less intimidating for the struggling learner, and it is a great form of mentorship and peer feedback. There's professional remediation. Perhaps you're dealing with a resident who frequently calls out sick or does not report to their clinical duties on time. Perhaps you are concerned for diversion or substance use disorder. Maybe there's a resident in your program who posted something on social media that violates the patient's privacy or even just is extremely disrespectful. The scope here of professional challenges is tremendous. First, I will say if there is a concern for substance use disorder or diversion, this should be assessed formally and comprehensively by a medical evaluation. In our institution, there is something called the Fitness for Duty evaluation, which is carefully coordinated by the program leadership with support of the chair, the graduate medical education office, the designated institutional official. This involves removing the resident from clinical duties and, again, drug testing as well as a comprehensive medical evaluation. Even if substance use disorder is not identified, oftentimes there'll be other concerns that are uncovered for which the institution or the department has wonderful resources that can be a tremendous help to the residents. In our department, we have a director of professionalism. This is someone who offers to meet with our residents to coach them. Perhaps you have a resident who has frequent uncivil interactions with their peers and colleagues and may benefit from coaching and redirection. We also have an ombuds person in our department. This is a completely neutral faculty member who is not affiliated with the residency program, who's not a chair, who's not a vice chair. It is someone that the residents can go speak to about any concerns in the learning and working environment. And I find that in our department, she's been very helpful in coaching our residents in the right direction and also redirecting them to resources for support. Please recognize that there will be issues that come to your attention as a leader that may be too big and large for you to handle or for your department to handle. Any issue of harassment, physical, sexual, has to be escalated to the university or hospital, and every institution has their own protocols. I also do believe that a close affiliation with the Department of Psychiatry, as I've alluded to in the past, is extremely useful in helping our residents. Residents who struggle with professionalism also are struggling with other things: depression, anxiety, stress management, and speaking to a provider who isn't affiliated with the department could be extremely helpful. This table is from an article we discussed already in anesthesiology that looked at performance gaps in residency and how that correlates with graduation and board certification rates. And as you can see, though I've discussed academic, clinical, and professionalism remediation, many learners will struggle in not just one of these areas, but have overlapping areas of deficiency. And many of the remediation tools are ones that we've already discussed, but if you look at the bottom of the table, there's this concept of self-evaluation or 360 evaluations, which are extremely interesting. The learner will perform their own self-assessment and also seek evaluations from not just faculty, but perhaps peers, nursing, technicians. And it's a great way to collect diverse perspectives, but also hold the learner accountable for being an active participant in this process and really thinking about what their own weaknesses are. This is an article from Academic Medicine that discusses the concept of failure to fail. We all want our residents on remediation to progress to zone 2 or 1, so to improve. But there are oftentimes well-meaning remediators and faculty who will try too often to keep keep trying beyond the point where improvement is likely to occur. And we all have to recognize as programs and departments that there are individuals who are unlikely to thrive as medical professionals and may drop to zone 4 or 5, which includes probation and exclusion or termination. In an article published in Pediatric Anesthesiology, they cited that 20% of program directors said they avoid the issue of problem residents or struggling learners for fear of legal retribution. And we do know that navigating the difficult learner is emotionally taxing and extremely time-consuming for faculty. And in today's learning and working environment, we know there is also an extremely high rate of faculty attrition at academic medical centers across the nation and across the world. There's a paucity of faculty development programs, a paucity of resources to support the career and growth of clinician educators, which is what makes this particular topic challenging for all of us. It is important as a leader in graduate medical education to realize when your department can assist a struggling learner and when it's important to involve the institution or graduate medical education. There are individualized remediation plans that are very formal legal documents that are composed by the program director in consultation with the designated institutional official. They do involve legal and HR support. They require formal attestations and signatures. They are oftentimes drafted with a very specific timeline. They outline core competencies and areas of deficiencies. And as you can see, they state that failure to progress can result in non-progression to the next PGY1 year or dismissal. And it is important to realize when you may need this type of support from your institution. It's extremely important to align key stakeholders. Remember that legal counsel doesn't represent the program director, it doesn't represent the chair or the department, it represents the university and hospital, which is why it's really important to ground all of this in the interest of patient safety and outcomes, as well as our duty to our patients and the public, and our specialty in upholding the highest standards of care. This is a photograph of my new clinical anesthesiology residents in their scrubs alongside my graduating seniors. It really is a cycle that takes tremendous work, but is also extremely rewarding. And you as faculty probably don't get enough thank you and recognition for all your work in training the next generation of anesthesiologists, particularly our struggling learners. So thank you for inviting me here today and for your investment in developing and helping our field.